so excited to have you here. So today we're going to be talking about my favorite topic, speech-language literacy disorders in school-age children with psychiatric impairments. Today's objectives are going to be explaining the comorbidity between language impairments and psychiatric disturbances in school-age children, describing language and literacy deficits of school-age children with psychiatric impairments, and also listing warning signs of language and literacy deficits in school-age children, which warrant the referral to speech-language pathologists for potential assessment. So one of the first things that I wanted to cover is the concept of developmental language disorder. That is a relatively new term which has emerged in the past several years as a result of something called Project Catalyze, or the Catalyze Consortium out of UK. And it is a combined effort of a number of speech-language pathologists across the world in order to create a label for language disorders which is uniform and which can explain what exactly is happening when we are using terms, this child has a language disorder. So previously, we had numerous number of labels. We had referred to children with language disorders as, in the olden days, we referred to them as having aphasia or childhood aphasia. We had referred to them as having a specific language impairment. We had referred to them as having language difficulties, and so on and so forth. So we had a plethora of terms, and now we're attempting to unify all of that terminology into something what we call developmental language disorder, or DLD. Essentially, DLD applies to any children who have difficulty comprehending what is being said to them, as well as expressing selves. And it's unrelated to obvious biomedical issues. For example, it is not related to having an autism spectrum disorder. It is not related to a hearing impairment. It is not related to an intellectual disability, and so on and so forth. In other words, these kids appear to have normal development in all areas with the exception of language, which is not developing according to typical trajectories. This recent name really better reflects the type of difficulties that children present with. It also emphasizes the point that these difficulties will persist into adulthood, they significantly impact functioning, and that they will require additional assistance. In other words, these children will require special education placements, they will require SLP, assessment and treatment services, they may require resource room services, they may require reading specialist assistance, and so on and so forth. So this is kind of an easy infographic developed by the Royal College of Speech and Language Therapists up in UK. And it shows you when is it appropriate to use the term developmental language disorder. That, it explains that the child has language difficulties. They create barriers to communication and to learning in everyday life. These language problems are not likely to resolve before school age. They are not likely to resolve by 5 years of age. And these problems are not known to be associated with any biomedical condition, any traumatic brain injury, any genetic syndromes, and so on and so forth. Now today, we're actually going to deviate slightly from speaking about developmental language disorder, because our topic today is actually language disorders associated with biomedical condition X, and that is highlighted in yellow. Today, we're speaking about children with language disorders, and those language disorders are associated with or comorbid with psychiatric diagnoses. So that's what we will focus on for our presentation for today. Now, briefly to describe what kind of speech, language, and communication needs do children with difficulties present with, here's another infographic for you, which is shared with permission of Dr. Dorothy Bishop. So, if children have developmental language disorder, that disorder may affect their abilities in several different areas. It can affect their syntax, it can affect their morphology, It can, affect their semantic abilities, their word-finding issues, their social communication skills, as well as their verbal learning and memory. Now, these language difficulties will also affect their later literacy development. All language disorders, if not addressed in a timely manner, or if um, there is a significant degree of impairment, they will develop into learning disabilities. While it may not be as apparent with children whose language difficulties were more subtle, it will be very apparent with children whose language difficulties were very significantly pronounced. Now, we also traditionally, when we think of the work of a speech and language therapist, most people associate what speech and language therapists do is what we have on, the right of my screen, and that is in the left of your screen, and that would be speech sound disorders, or SSD. So most professionals and parents tend to initially associate speech therapists with their work on speech sound disorders, pronunciation, enunciation, and so on and so forth. However, in our particular setting, in Rutgers Day School, we actually do not have too many children with what we call speech sound disorders or phonological disorders. We may have several children who present with some articulation difficulties, such as R and L sound distortions. However, that is not their main difficulty. Their main difficulty is language impairment, which is affecting their ability to express and communicate effectively. So these are the sampling of children we're going to be speaking about today, and that is our population, which is being served in Rutgers Day School, as well as being served by UBHC in a variety of school-based programs. We are speaking about children with a variety of psychiatric conditions. And here, since the majority of people are familiar with autism the most, I'm placing here a number of non-autistic psychiatric diagnoses, so it becomes clear what kind of psychiatric impairments can be associated with language difficulties. And that, of course, includes mood disorders, anxiety disorders, attention and behavior disorders, reactive attachment disorders, and so on and so forth. So there is a significant comorbidity between psychiatric impairments and language disorders. In fact, depending on which study that we look at, that comorbidity starts at 37%, but goes as high as 89%, as summarized by a number of researchers. So children with language disorders are at risk for developing psychiatric conditions, typically anxiety and depression. However, children with psychiatric diagnoses often have very significant comorbid language deficits. And these language deficits, according to certain studies, can go on undetected for years. Here's an example. In a study, which is by now, about 20 years old, so Cohen and her colleagues actually did a study which found that approximately 40% of children between 7 and 14 years of age who had been referred purely for psychiatric issues actually had undetected language impairment that nobody had previously suspected. That is a huge number of kids, whereas everybody was thinking, oh, these are just emotional behavioral disturbances, they're just behavioral deficits, but these kids had the intensity of those problems because they had a language impairment. And because that language impairment wasn't apparent, it was really exacerbating their psychiatric conditions. Now, another more recent study done by Alexandra Hollow and her colleagues, they did a meta-analysis. They looked at 22 studies which reported result of language assessments in children with EBD, or emotional behavioral disturbances. Now, these children had no prior history of a language impairment at all. They had never been flagged. But the most interesting thing is, which came out of those studies, they found that more than 80% of those kids displayed below average language performance on several common standardized assessments. In fact, 46% of those kids were actually moderately to severely impaired, and they had never been flagged before for having language deficits. So now let's talk about why this is such a huge, significant problem, especially for our particular setting, which is the psychiatric setting. Now, when these kids are spending years under the radar for medical and educational professionals, it's basically results in tremendously poor outcomes for those children. Not only does it adversely affect academic functioning, it can lead to school dropout rates. It could lead to incarceration. So the outcomes are really very, very, very poor. In fact, when we look at studies done by researchers on language abilities of juvenile offenders, we see overwhelming number of people studied essentially having very poor language skills. Many of those people were flagged by the school system as having learning disabilities, and they were placed in special education classrooms. But then there were numerous others who report never having seen a speech-language pathologist, never having received special education classifications of any kind, and essentially being failed by the system and released into the world from the school system as functionally illiterate. So in our specialized settings, such as Rutgers Day School, it also plays into one very important factor. When we accept children into our program, we also accept them for psychiatric as well as psychotherapeutic services. These kids need to have adequate language abilities in order to understand and benefit from psychotherapy. And unfortunately, many children who do enter the school have such a significant language impairment that they can very minimally benefit from psychotherapy unless their language abilities continue to be steadily improved through the involvement of speech pathologists, reading specialists, and so on and so forth. So these services are very critical for psychiatric population, and they require very significant amount of support, much more so even than children with language disorders who do not have comorbid psychiatric difficulties. Just to briefly cover speech sound disorders, because I'm being redundant. So I'm often asked this question: do speech sound disorders, or does articulation impairment or phonological impairment have any impact on developing a psychiatric impairment, or does it have any impact on developing later literacy deficits in the areas of reading, writing, and spelling? And generally, depending on studies, it may, but there has to be a particular type of a setup in order for that to happen. So for example, just because somebody had a speech sound disorder in childhood does not automatically flag them for having a literacy impairment in the areas of reading, writing, and spelling. However, if somebody has co-occurring language deficits, which adversely impact their literacy abilities, then that risk increases actually significantly and exponentially. Family risk of dyslexia, special education placements, reading deficits, or any literacy-based deficits adversely affects outcomes as well. But speech sound disorders alone, such as RNL distortions, or just mild speech impediment, for lack of better words, really possesses few or no psychiatric effects on functioning. And that is something that I wanted to explicitly mention before moving on to what type of language difficulties do students with psychiatric impairments present with. So one of the first things that becomes very apparent when we work with children with psychiatric impairments is that their listening comprehension and their verbal expression is affected to some degree. In some children, it's very pronounced almost right away. In other children, you may need to dig a little bit deeper before that is revealed and uncovered. Typically, when you have difficulties in the area of grammar, in the area of vocabulary, in the area of pragmatics, or how you use your language to interact with other people, that typically significantly overlaps with psychiatric disorders. Having listening comprehension deficits, or what we call receptive language deficits, it's a very high-risk indicator. In fact, people whose, not people, but children whose receptive language or listening comprehension abilities appear to be impaired versus only their expressive language being impaired, those kids really have much poorer outcomes versus the kids where their listening comprehension was relatively intact or not as affected. So that is a very significant indicator when we are dealing with kids who have very significant difficulty following our directions, responding to our questions, and just keep asking us for repetition, appear that they're confused or don't understand something. That's a huge indicator that their difficulties are going to last longer, be more pronounced, affect their literacy skills, and affect their life outcomes to a greater degree versus kids whose listening comprehension skills were not as affected versus their expressive language. So another thing that I wanted to mention is that in school setting, especially in our setting, Rutgers Day School, the type of children we receive more frequently are the children with significant externalizing behaviors. In other words, we're much more likely to receive children who are being very aggressive and physically disruptive in their respective school settings versus children who may have more symptoms of anxiety, anxiety, selective mutism, and so on and so forth. It's kind of follows the, squeaky wheel gets the grease phenomenon, where we're much more likely to receive kids who are very overtly behaviorally disruptive because, schools generally tend to have difficulty managing these kids effectively in school settings versus children who are very quiet, who are internalizers, who kind of fly under the radar. They can last far longer in the school system before they are flagged and before they end up receiving appropriate services. So now, this is my favorite portion of the presentation because I get to ask the audience, how do we recognize if children's language abilities in a variety of areas are impaired? So how do professionals know, okay, I have a problem over here? Essentially, knowing typical language development really matters. It matters for parents, it matters for psychotherapists, psychiatrists, educators. Knowing what's typical and what's atypical, generally speaking, is what will raise a flag. And that's what will say, okay, something is not right, we need to refer this child, something needs to be done. So when we look at some of the studies on psychiatric diagnosis and language impairment, we start seeing very particular type of patterns. We start seeing that children with behavioral disturbances are overwhelmingly diagnosed with what we call pragmatic language deficits. Also, we could refer to them as social communication language deficits. They have externalizing behaviors. They're acting out in school, so they present with difficulty kind of appropriately, pragmatically, and socially interacting with others, which is why they are flagged. So students with emotional behavioral disturbances have a very high co-occurrence rates of antisocial behavior and language deficits. Again, the same study by Cohen and colleagues in '98 found that these students have very significant difficulty engaging in emotion decoding and social problem solving. These students have very significant difficulty engaging moods, understanding how people feel, when presented with certain social scenarios. They really had no effective solutions to deal with them, and so on and so forth. A study by Brian found that they have really significant difficulty understanding someone else's affective state. A study by Baltox and Simmons found that these kids engage in numerous transgressions, conversation rule violations. They frequently speak when their speaker has absolutely no background knowledge and information on what they're referring to. They frequently have behavioral outbursts versus using language. So for example, if a child is having some sort of a difficulty, they're much more likely to throw a chair rather than, speak and try to verbally reason and try to kind of de-escalate themselves and come down and use coping strategies not to escalate further. They had decreased language use for problem solving. They really did not know certain, um, you know, meta-linguistic and metacognitive terms to, such as solve and justify, and they didn't know how to engage in that. And their communication style was deemed to be inappropriate. Just a few more clarifications regarding these children's social pragmatic language abilities. A study by Dr. Yvette Heider in 2003 found that pragmatics is the area of language most affected for students with emotional behavioral disturbances. I do not think that is a surprise to anyone here in this room. A study by Goldman in 1987, they did parental reports. And they looked at parental reports, and parents reported that children with language and learning deficits, they didn't use their language for problem solving, and instead they reacted physically, such as throwing tantrums, storming out of the room. So they really had significant difficulty in relating to others using language. They tended to relate to others using behavior as a form of communication. When we started looking into social skills, all of the studies show that, for example, preschool boys diagnosed with oppositional defiant disorder, they had poor vocabularies for describing affective states than their typically developing peers. So they had difficulty recognizing moods, emotions, and how somebody was feeling. They also, we now know that they have poor perspective-taking abilities. They have very significant difficulty putting themselves into other people's shoes and trying to decode and interpret what are they thinking, what are they feeling, how is their thinking and how are their feelings different from mine. They have significant difficulty doing that. This is a study by Bishop and Bard in 2001 showed that children at that point diagnosed with ADHD had underlying difficulties in social understanding. Another study which looked at kids with conduct disorder, it actually found that their social pragmatic deficits are just as severe as children diagnosed with autism. So study upon study upon study is finding this very significant social communication, social pragmatic language deficits in these children. Now, these studies focus just on one aspect, which is social communication. Working in our setting, in Rutgers Day School, we know that far more language abilities are affected, and that is their comprehension, that is their ability to express themselves, it is their narrative skills, as well as it's their literacy abilities, it's their ability to read, it's their ability to write, it's their ability to spell. All of that is also affected, but in those days, there was a significant focus on social communication, which is why these studies are listed as them having very significant social communication difficulties. Now, it is, for a number of educators, professionals, and for parents, it is difficult to recognize social communication deficits. These social communication deficits, they may be interpreted as pure, quote unquote, pure behaviors. They may be perceived just as challenging behaviors and nothing else. Very severe cases could be misdiagnosed as having oppositional defiant disorder or some sort of a psychiatric impairment. And it's not unusual in our setting, in Rutgers Day School, to receive very young children under 6 years of age with very severe to profound language impairment. And because those children have such significant difficulties communicating with others, and because they act out with behaviors, it's not unusual for those children to come in with some pretty hardcore psychiatric diagnoses, when in reality, they didn't even have adequate language to justify the severity of their diagnosis at such a young age. So language impairment and severity of language impairment can make a huge difference and can end up having somebody being psychiatrically misdiagnosed with a different disorder which they may have. So we typically recognize that somebody's language abilities are not quite all right when we look at common teacher and parent complaints. There is, kids may ignore presented directions, they can follow their own agenda, they may inappropriately act out, they may act very immaturely or act like a clown in a classroom. And they're often described as clueless. They're clueless of their surroundings, they're clueless of the impact they have on other people. One of the things we can, so some of the things that we kind of need to keep in the back of our head when we are speaking or, reviewing a situation in which we have a child who is having some behavioral difficulties, is we can start thinking about what they're able to or not able to do social communication-wise, because it's really going to alert us fairly quickly regarding the need for a social communication assessment or a comprehensive language and literacy assessment and so on and so forth. Can these kids label facial expressions? And we're speaking typically about beyond happy, mad, sad. Can they recognize disgust? Can they recognize excitement? Can they recognize, disappointment? And so on and so forth. Can they recognize moods of other people? Can they identify their own feelings beyond happy, mad, sad? And it's interesting, especially in our setting, when you start asking young children, how do you feel? And the responses invariably will be, I'm mad, I'm mad. But in reality, the child may be experiencing a host of other emotions. The child may be disappointed, but all they can express is, I'm mad. The child may be frightened by something, but all they can express is, I'm mad. So it's a very common feeling of kids who are, language impaired, to be unable to state any emotions besides just recognizing, I'm so mad. Oftentimes, when you ask them to recognize somebody else's feelings, especially if that person is basically feeling calm and looking calm, they will look at you and they will not be able to do it. They sort of will stare and they say, I don't know. And that's a very common default response. I don't know how you feel. They will try to take a stab at it and say, well, you're happy. And sometimes I will tell them back, but I'm not, but how can you tell if I'm happy? I'm not smiling. What's that state where I'm just sitting here just like that? They're unable to recognize calm. I don't think, and this goes back to like trauma-informed care. I don't think there's, it's very difficult when they have very traumatized children who come from such complex environments into our setting. It's very difficult for them to recognize and do certain things that we adults who work, or are around typically developing children, who have our own typically developing children, take for granted. They have difficulty initiating social interactions, and that, of course, can manifest in a very wide variety of ways. Their social interactions may be inappropriate. They may be clueless about initiating their social interactions. Their social interactions may be, for lack of better words, maladaptive. They have very significant difficulties interpreting social situations. One example of that would be when, a teacher may be speaking to another adult, speaking to another child, they're deeply engaged in a very serious conversation, and a child just sort of cluelessly comes up and interrupts them, and then, of course, will kind of earn them the ire of the teacher. But they legitimately have no clue about how to socially interact with others. They legitimately have no clue how to read a situation, how to be in a room with others and interact with them appropriately. They have very significant difficulty creating and conveying messages to speakers. Their messages tend to be very decontextualized. They lack a lot of relevant details. They have something that they call poor anaphoric referencing. They may refer non-specifically to others as he or she without, referring to them by their name. without explaining that I'm talking about a teacher, I'm talking about a friend, I'm talking about, a parent or an aunt. It's very decontextualized. And something that is very difficult to recognize in our setting, but something that's very easy to recognize in a typical school setting, they have very significant difficulties relating to peers. Peers are a wonderful disability barometer. I heard that expression several years ago, and I can't quite recall who first stated it, but it really kind of struck the perfect chord with me, because typically developing children are very quick to recognize a typical social behavior. Young kids, even as young as preschool, sometimes even as young as toddlers, they will recognize it, they will isolate it, and they will let others know something is not quite okay, something is not appropriate. It's very difficult to, it's a lot more difficult to recognize that in our setting, because we have such severely psychiatrically impaired kids who are acting, in a, different pattern from typically developing peers. But even in our setting, when we go into our classrooms, we are able to recognize kids whose social interaction difficulties are more apparent than some of their other peers. And this is especially noticeable when you have a classroom which is joined by a brand new student. So when we have our students who have been there for a few years, who, for lack of better words, have been therapized, and a new student, kind of just fresh through the doors, enters it, there is a huge difference in how they socially interact with others that sort of flags them as being more atypically functioning in relationship to other peers. So let's talk about some kind of a very rough sampling of typical language development of school-age children. Because this presentation is not intended, for speech-language pathologists, these are slightly kind of a more general language milestones, and it's intended for pretty much all professionals to quickly use and recognize. Okay, so this is how, these are the symptoms, this is what it looks like, this is how it's going to help me to flag some atypical behavior. Okay, so just wanted to briefly discuss the hierarchy of language development. Especially, so some of the milestones not mentioned here are, of course, milestones pertaining to younger children. Play is, of course, hugely important, and so is meaningful interaction with your environment, and so is babbling, so is jargon, and so on and so forth. But typically speaking, listening abilities develop before expressive language. You need to be able to understand words, phrases, sentences, and stories. And as your listening abilities develop, your expressive language abilities develop concomitantly. In typically developing children, what you understand tends to be higher than what you express. The same goes when we're discussing literacy and our vocabulary knowledge of when we speak, when we read, and when we write. We use different vocabularies during all different three tasks. So similarly, you need to understand before you can speak. Now, interestingly, in some subset of children with autism, they may have more verbal output rather than, their expressive language abilities appear to be on the surface higher than their receptive language abilities when they're younger, and that's definitely a significant red flag for learning, because that indicates that their comprehension needs to be increased before they can meaningfully continue learning and expressing themselves and retaining something from their environment. So, your expressive language, you need to speak words, phrases, sentences, engage in conversations, your ability to produce stories, and your narrative abilities. They're very strongly correlated with future literacy outcomes. So, in other words, the better you are at telling stories, the better you are going to be at reading and being a comprehender. However, when you are reading, you don't just read books, for general knowledge on general topics. You don't just read for pleasure. you also need to engage in something what we call disciplinary literacy. You need to have vocabulary for science and for social studies, for geometry, for chemistry, for physics, and so on and so forth. As these children are starting to read, they're also starting to spell. Reading and spelling have a kind of an interesting relationship, and it's a circular relationship. Your ability to read better improves your spelling, but your ability to spell can also positively influence your reading. And then, of course, we have writing, which is the most kind of a complex of all the literacy skills. We start, word sentences, short stories, essays, and writing is, of course, kind of a culmination of all the children's linguistic abilities. Children with language and literacy deficits tend to be poor writers. They have very significant difficulty with organizing their output and creating a novel output. So that definitely is a cause for concern, and it's typically flagged when the kids tend to be generally older. Typically, even though speech pathologists are becoming more and more involved in treating literacy, writing sort of happens to be a bit in a back burner in a number of places, and it shouldn't, because working on kids with writing actually improves their abilities in all other areas of literacy and language. So language develops in a continuum. We start from listening comprehension, we end up with writing. Effective language interventions provided by speech-language pathologists will involve focus on reading, writing, and spelling in conjunction with listening comprehension, oral expression, and social communication. So, and that is kind of very important to know, because oftentimes, especially when we have like new staff members coming from other settings, they're not quite sure about what speech pathologists do. And the default kind of a reaction is, oh, they work on pronunciation or enunciation and speech sound disorders. But, trained speech pathologists, especially for our setting, which is very specialized, we focus on language, we focus on literacy, we focus on metacognitive and metalinguistic aspects of language. So we really try to improve kids' abilities in all academic areas. So here are some basic typical language expectations of your school-age kids. And because this is a lecture intended for school-age populations, we're starting at 6 as opposed to my early intervention lecture, which typically starts much, much earlier. So a typical 6-year-old is expected to basically produce stories which make sense, which center around a theme and contain a logical chain of events. They're able to take part in longer conversations. Their grammar will be fairly typical and very similar to that of an adult, which includes complex sentences as well, except their vocabulary will be, of course, commensurate with age and not terribly sophisticated. They're, as compared to adults, of course. Their speech will be clear and it will be easy to understand. Now, this is what a typical 6 and 7-year-old looks like. Now, when is it a red flag, and when should these kids be referred for speech-language assessments or screening? Basically, when you're interviewing a child and you see that the child has significant difficulty responding appropriately to questions or instructions. They're asking you, what'd you say? Can you say that again? And so on and so forth. Or they simply produce incoherent responses upon the presentation of a particular question. Child has difficulty speaking in longer sentences, so what we call complex sentences with independent and dependent clauses. They produce their words in the wrong order. Their sentences are too simple, too short, and their vocabulary is immature as compared to other 6 and 7-year-olds their age. They may have difficulty maintaining conversation. The adult may ask them a question and then they're unable to ask something back of an adult, or their answers are too short, too brief, and too limiting. They may not be able to answer very basic problem-solving questions pertaining to daily life activities. And they may be showing very atypical social functioning as compared to other peers. That's typically recognized as other peers are doing something, the child will be doing something completely different, and it's sort of socially flagged by parents or teachers almost like right away upon maybe entering the classroom or on a field trip and so on and so forth. When we talk about typical expectations between 8 and 11 years of age, we're talking about kids whose language sophistication improves exponentially. They understand more and more words with multiple meanings. They understand implied or suggested information in stories and conversations. They understand metaphors and other abstract meanings, or they're beginning to. And they can listen and draw conclusions in subject area learning activities. They start forming opinions based on evidence. They start displaying greater and greater language sophistication. They can follow a story easily without looking at the pictures. They could produce a summary of main ideas, of stories, and of messages. They're learning new words, and they're making associations between related information. They're now able to evaluate output. They can relay a sequence of events or complicated stories. They could talk about a variety of complex episodes in stories. And they really have greater perspective-taking abilities. They're aware of other people's point of view and their opinions. However, we know that these children require referral for an assessment if they start presenting with the following type of a display. So if they have difficulty following instructions without prompting, if they require significant prompting to do, even basic things, such as, go to your folder, take out your math homework, open your work on page so and so, and so on and so forth. If we are flagging these kids as having very significant visible difficulties with memory, if they take a significantly long time processing information and a very long time to answer questions, if they're not able to follow messages or follow a story without a lot of repetitions and a lot of questions, if they continue to present with very limited vocabulary as compared to other kids that age, if when they're speaking they use very nonspecific vocabulary such as thing, stuff, if they use a lot of fillers in their sentences, like, if they take significant pauses while they're engaging in conversation, if they stop mid-sentence and they start thinking, if they have significant what we call word retrieval of word-finding difficulties, their speech is very tangential, it has a lot of mazes or kind of a very circumlocutory, if their speech has a lot of false starts, interruptions, repetitions of whole words and phrases, that is definitely a significant cause of concern. If they show very poor reasoning and problem-solving abilities as commensurate to peers, for example, if they take what you say quite literally, which shows that they are unable to comprehend figurative and ambiguous language. They don't understand irony and sarcasm. If a child has difficulty following a shared topic in a conversation, some of the kids in our program, as well as some of the kids elsewhere, they only want to talk about things that interest them. Oftentimes, you may see their listeners or speakers become sort of so frustrated, they sort of walk away and they start speaking to them. And the child is still speaking, even though there is no audience left. When they make a lot of errors in grammatical errors or syntactic errors in spoken language. And I mentioned before when they use nonspecific words quite a bit. When we talk about adolescence or early adolescence, about 12 and 13 years of age, we're talking about kids who ought to be able to summarize ideas and stories or messages, and who have quite an increase in their metalinguistic and metacognitive vocabulary. They should be able to discuss abstract concepts and ideas which are not within their personal experience. But it's so interesting how many of the kids with social communication difficulties and many of the kids with psychiatric impairments will frequently tell us, I don't know what this is talking about. I can't relate to that. They frequently may use the words, that never happened to me, so how would I know? Or I can't relate to that. So that's a very significant, I see our chief unit psychiatrist laughing because he has encountered that on numerous occasions. But it is, we have kids who will just tell you, I don't know what this is about. How would I know? We have several kids who particularly like to engage the how do I know strategy. But typically developing kids, even if they've never been in a particular situation, they're able to take themselves and put themselves into that situation. And they're able to still make some sort of functional judgments about that situation and then relay the outcome verbally. They can use, we want to refer them if they can't use language to manipulate behaviors, feelings, and attitudes of other people. And that part of using language is very, very important. If they're trying to manipulate other people by behavior, and typically that has a negative connotation, then we do not, that is a significant red flag. Typical adolescents should be able to use language to kind of cajole, persuade, get what they want, and so on and so forth. They can transition from topic to topic with ease. They are already, in middle school, so that should definitely be happening. They can definitely adjust their vocabulary and modify their language style to accommodate different listeners. They will, when speaking to different audiences, teachers, parents, adults, friends, or toddlers and younger peers, they can very dramatically change their language to kind of adjust to them. But we notice that some of our, children whom we work with definitely do not have those abilities to adjust that quickly and transition that quickly and change between audiences. So what can we ask? And this goes back, this is like an homage to Dr. Petty. What can we ask when we're speaking to them and when we are, interviewing them? Do you have trouble understanding what teachers or other kids are telling you? If they're saying, I don't have trouble, probing deeper and asking kind of more targeted and relevant questions to see whether or not that's really the case. Do you have trouble telling what you want to say to others? Do you have trouble expressing yourself to others? How do you feel when others don't understand you? And of course here, the one limitation I mentioned before, some kids really do lack insight into their own linguistic strengths and weaknesses. Some kids will continue to maintain, even in the presence of very significant language impairment, that they do not have any difficulties. And right, when they're getting language therapy 3 times a week. Now remember, some of that has nothing to do with lack of comprehension. Some of it has to do with pride. Nobody wants to be different. Nobody wants to, nobody wants to kind of, they still have, they're exactly the same as typically developing kids. They have their pride, they have their emotions, and they sometimes they want to protect themselves at, at any cost, which is completely understandable and, and completely kind of justifiable to me personally. But at the same time, those are exactly the kids who may be getting, language therapy services several times a week. So there is that kind of like dichotomy of presentation that we need to be aware of, when we're dealing with them. Some kids will simply not admit. One way we can quickly check whether or not they are a reliable informant. If a school-age child is typically, like I mentioned before, ought to produce a personal narrative. They ought to be able to talk about things within their experience. Personal narratives require the speaker to organize an account or recount of past experiences. One quick way to figure out and to kind of eyeball the extent of their language abilities is to ask them to recount that narrative and then simply see whether or not their verbal output is coherent and cohesive, or whether it's tangential and doesn't make sense and leaves the listener with more questions rather than answers. It's a very kind of effective way to tax somebody's system because it's unplanned, so it requires you to organize massive amount of resources. It requires coordination of multiple executive functions between memory and processing and organization and initiation and so on and so forth. And also, that personal story has to be somewhat interesting to the listeners. If somebody is going on and on for 5 minutes about what they did this weekend, it's not going to work out. You will lose your listeners' attention. But we have kids who will talk about it for 10 minutes. We have kids whose teachers may already indicate to them both verbally and non-verbally, thank you, I've heard enough, and yet they will continue to speak about that, thereby indicating that they have difficulty they have difficulty understanding their effect on their listeners and their speakers. They have difficulty reading the room, reading the space, reading other children, and trying to figure out, when is a good time to stop, or how brief or how lengthy I should be before I lose my audience. Some more information about personal narratives. And one of the reasons why I chose personal narratives, because there have been studies on them in child psychiatry. And they have been used both as a psychotherapeutic evaluation, but also as an intervention in a number of studies. They're really relevant to psychiatrists as well as psychologists and psychotherapists because it has to do with the following factors. Can a child maintain a topic of their story? Can a child provide enough information, enough facts and details? Are they capable of rendering an opinion, a value judgment, and so on and so forth? Can they put events in chronological order without confusing their listener, without confusing their audience? Are they using pronouns to refer to people, or are they labeling, everything either as stuff or people as he or she? And on top of everything, are they reversing pronouns and sometimes referring to a she as a he? It could also happen. Is their story fluent? Fluent not in the sense that are they stuttering, but is their story fluent as in how many mazes and linguistic reformulations does it have? Are they constantly using words like like, let me think, whatchamacallit? So that would be an example of stories and personal narratives which are linguistically disfluent. So those were the examples of how to recognize some of the language difficulties in our kids. But I also wanted to add how to recognize literacy deficits in young children. More and more, speech pathologists as well as other professionals are becoming to realize that we play an integral role in assessing and remediating literacy difficulties in the areas of phonological awareness, reading, writing, and spelling. So it is also important to include literacy in this presentation because sometimes language difficulties may not be as overt. So sometimes a child may reach school age and people will think, okay, they have relatively intact language abilities. There may be an internalizer, so their social communication abilities may not be as apparent. So that's another reason why it's also important to recognize warning signs of literacy deficits. Because sometimes kids who get flagged for an assessment, especially in my setting, they are not flagged for an assessment due to their social communication deficits. They get flagged for an assessment because they reach a particular age and they're unable to read. So what are some warning signs? Well, one of the things is it's a documented history of language impairment. For example, these kids may have received early intervention services. They may have been in the preschool disabled program. So they may have had issues with language for quite a while. Perhaps even if they were developing language-wise fairly okay, they may be flagged around preschool age because of certain things they're unable to do that their peers are able to do. For example, when you have a 4-year-old and that 4-year-old has difficulty remembering nursery rhymes and songs, same as peers, it is a little bit disconcerting because kids that age typically basically know quite a few of them. But if this is somebody who's always having difficulty saying that and remembering that, that's a red flag. So the child has very significant difficulty remembering letters of the alphabet. And we're not talking about when somebody just showed it to them once, but after multiple exposures, they still have significant difficulty doing that. They have trouble recognizing simple rhyming words or producing simple rhyming words. These kids may also have a documented family history of language and literacy impairment in the family. They may also have a family history of special education placements in the family. Those would all be some warning signs of literacy in young kids. So they can't recall or produce basic nursery rhymes. They may not recognize letters of their own name. They can't recognize rhyming words, like fat cat sat in the mat, that they can't recognize that cat and sat and mat, for example, rhyme. They may have trouble learning new words. They have poor memory for names. They may mishear and mispronounce novel words or names. So for example, one common mispronunciation may be hospital, may be produced as hospital over and over again, but they're not at an age where they're toddlers and it's cute. They're like already of an age where it's definitely, a red flag, and all the other kids can definitely pronounce it appropriately. And then of course, social immaturity. Their parents report them to function significantly younger than siblings that age, than peers that age, and so on and so forth. For warning signs of reading difficulties in school-age children, we have difficulty engaging in phonological awareness tasks. So for example, difficulty figuring out how many syllables are in a word. That would be an example of a phonological awareness task versus a phonemic awareness task where we might ask them to isolate initial or final sounds in words. We can ask them to kind of blend sounds together to produce a word, where we may ask them to substitute one sound in the beginning or the end of a word and say, okay, well, what word do we have left? They also have difficulty reading any short texts. They guess their words. They omit or add sounds, articles, morphological endings such as ing, ed, and so on and so forth. They have significant letter reversals. We're talking such as B and D letter reversal, which goes beyond the second grade and continues to be consistent in the third, fourth grade, and so on, which is atypical. They have poor reading fluency skills. They can't read a short text without a lot of mistakes, interruptions, and it doesn't sound, like it flows well. They are flagged consistently as reading below their grade level or even several years below their grade level. And they have something what we call poor morphological awareness skills. So for example, they can't recognize that you can add a bunch of suffixes or prefixes to a word. It's going to change that word slightly, but it's still the same word. So for example, I use here the root word struct, or as in to build. So they can't recognize that the word structure, reconstruction, deconstruction, they're basically kind of variations of the same word. They still have the same root, but they have been changed in some meaningful way. What they they consider that all novel words, which is very difficult when it comes to comprehension of higher order text. It's very difficult when it comes to recognition of vocabulary words in text and recognizing text vocabulary based on context. They, of course, because they have all of these difficulties, they have poor reading comprehension abilities, and many, but not all, may end up having poor spelling abilities. Here are some examples, specific examples for K through first grade. They may guess words instead of attempting to sound them out. They may have difficulty counting words in sentences and breaking words into syllables. They may not engage in reading tasks. They may not be able to sound out all the sounds in basic words, such as bat. They would not be able to, you tell them, okay, tell me all the sounds in bat. They may say b, and then instead of saying at, they may end up saying bat, or b at, which is, which is not what they've been asked to do. So they have difficulty recognizing all the sounds in a particular word. They may have difficulty recognizing first and last sounds in short words, such as in map. You may ask them, what's the first sound in map? Even after you explain to them, this is the first sound, they may produce p instead of m, or they may produce a letter, m. And they have significant difficulty associating letters with sounds. So, just to talk about just to summarize everything that we've been kind of working on and talking about here. When we speak about communication difficulties, it's very important not to assume that these communication difficulties are coming due to inattention or emotional distress, because these issues may be purely due to what they used to call primary language impairment, another moniker, and now known as developmental language disorder. So it's very important not to assume, oh, they're having trouble because of these psychological processes or because of these psychiatric issues. Sometimes it is due to language. And in fact, in kids with psychiatric impairments, it is definitely very often due to language. Now, the problem is, if left untreated, these language deficits, they will persist. They will worsen over time. And these kids face relatively poor outcomes in childhood through adolescence. So we know, based on studies, if we provide intervention earlier, the results are far more effective. That's why we need a differential diagnosis in order to rule out, language disorder associated with a biomedical condition such as, anxiety, depression, reactive attachment disorder, and so on and so forth. We want to know if the child's psychiatric status is further impacted by hidden language deficits. As such, the most effective approaches to identification and treatment are collaborative ones between, obviously, educators are included in that, but because of our setting, psychiatrists, psychotherapists, speech-language pathologists, and caregivers, all collaborating together, all recognizing these difficulties, all recognizing these issues, so these children can receive appropriate care and improve their school as well as social outcomes.